Welcome to our presentation on dentin dysplasia. Dentin dysplasia is a hereditary disorder that affects the dentin formation of both dentitions, maxillary and mandibular. Most individuals with dentin dysplasia will present with normal appearance in their crowns due to there not being any disruptions of the formation of enamel, the outermost layer in the tooth. Exceptions and differential diagnoses will be discussed later in the presentation. Shields' classification of dentin disorders: dentin dysplasia type 1, radicular dentin dysplasia, and dentin dysplasia type 2, coronal dentin dysplasia. DSPP gene is implicated in dentinogenesis imperfecta type 1 and type 2, as well as dentin dysplasia type 2. The DSPP gene is essential for making dentin sileophosphoprotein, which is found in chromosome 4. Once produced, the protein is cut into two smaller proteins, dentin sileoprotein and dentin phosphoprotein. Dentin dysplasia type 1 is associated with mutations in SMOC2, VPS4, SSUH2. In type 1 dentin dysplasia, also called radicular dentin dysplasia, the teeth are relatively normal in color and shape. The main clinical complaint from patients comes from the effects on the roots of the teeth, which results in misalignment, drifting, and tooth loss without trauma. Some cases have reported color change, with teeth appearing slightly bluish-brown and translucent. Although this is rare, the small pulp spaces may affect endodontic and restorative treatments. The disease management is lifelong because this disease affects both primary and adult dentitions. Type 2 dentin dysplasia, or coronal dentin dysplasia, is primarily a disease of the primary dentition and affects the crowns, as opposed to the root involvement of type 1. The crowns in the primary dentition have a similar presentation to teeth with the related disease dentinogenesis imperfecta, which is to say they have amber-like translucency and a variety of colors from yellow to blue-gray. The variety of colors changes depending on whether the teeth are observed with transmitted or reflected light. The permanent crowns in the adult dentition appear normal. Some studies have reported rapid abrasion of primary teeth. Incidence is disputed, and this disease may be more or less common than type 1 dentin dysplasia. Radiographs are important for the diagnosis of dentin dysplasia. Type 1 and type 2 have different changes in the roots that can only be seen via radiographs. In type 1 dentin dysplasia, the pulp chambers or root canal may be partially or totally obliterated before eruption in primary teeth. This may also occur in the permanent dentition, leaving a crescent-shaped remnant of pulp parallel to the CEJ. The roots of primary or permanent teeth will have a short, abnormal shape. They may appear blunted, similar to toroodontic teeth. Because of the blunting, molar roots may appear to have a shallow W shape. Periapical inflammatory diseases may be evident on the radiographs of non-carious teeth, which shows up as a periapical radiolucency. In contrast, type 2 dentin dysplasia will have pulp chambers in primary teeth that obliterate after eruption. The pulp chambers are filled with hypertrophic dentin, which causes the pulp to become flame or thistle-shaped as it obliterates the permanent dentition. The roots of teeth will appear normal in shape and proportion. Within the root canal, pulp stones may be present radiographically, often in the coronal third of the canal. Image A in the top right corner is a panoramic radiograph of a 10-year-old patient with dentin dysplasia type 1. The permanent molars 19 and 30 are congenitally missing, and the roots on tooth number 18, 20, and 21 are shortened. The same patient is depicted in the bottom right radiograph at age 13. The radiograph reveals arrested tooth formation on number 18, 20, and 21. Image D is a closer view of the arrested root formation on number 18 and number 20, and the lack of root formation on number 21. The image on the left shows a thistle-shaped pulp chamber in both the central and lateral incisors. This is due to the presence of pulp stones. The image on the right shows a flame-shaped pulp chamber in obliterated root canal space. Note that both radiographs reveal somewhat normal-shaped roots. The only differential interpretation for dentin dysplasia is dentinogenesis imperfecta. Both abnormalities can present with obliterated pulp chambers and abnormal tooth color. There are several forms of dentinogenesis imperfecta, each with their own etiology. Type 1 dentinogenesis imperfecta is a consequence of a mutation of COL1A1 and COL1A2 genes. This mutation also causes osteogenesis imperfecta. Type 2 and type 3 dentinogenesis imperfecta is caused by mutation in both the DSP and DSPP genes. Type 2 is more common as type 3 was only recorded in a small population found in Maryland. Dentin dysplasia does share the DSPP mutation but differs from dentinogenesis imperfecta by not being associated with the DSP, COL1A1 or COL1A2 mutations. General clinical characteristics of dentinogenesis imperfecta that distinguish it from dentin dysplasia include bulbous crowns with constricted CEJs and short, narrow roots. Dentin dysplasia presents with normal-shaped crowns and either normal-shaped roots in the case of dentin dysplasia type 2 or a near total absence of roots in the case of dentin dysplasia type 1. Thistle-shaped pulp chambers is characteristic of dentin dysplasia but is not always present. Additionally, periapical rarefying osteitis is more commonly seen in dentin dysplasia. Lastly, dentinogenesis imperfecta is substantially more common than dentin dysplasia. Dentinogenesis imperfecta occurs in 1 in 8,000 individuals, compared to the 1 in 100,000 individuals seen with dentin dysplasia. There are no specific treatment options for dentin dysplasia. Each treatment depends on the age and severity of the disease. An early diagnosis is critical to help retain the affected teeth. Once an early diagnosis has been established, one is able to immediately start preventative care. Preventative care includes prophylaxis with topical application of fluoride, oral hygiene instruction for maintenance at home, and clinical and radiographic exams should be done at each appointment. Cases of dentin dysplasia that involve short roots or hypermobility may exfoliate teeth, leading to spaces. These individuals should receive a retainer to prevent movement or exfoliation of other teeth. Endodontic treatment on these individuals may be difficult due to abnormal tooth morphology or short roots. It is important to keep in mind that preventative care may not be successful. There are more specific treatment options depending on the type of dentin dysplasia. Individuals with type 1 should receive prosthodontic therapy because of their short roots. In younger individuals, this includes stainless steel crowns to help with any type of wear or occlusal dimension. In the mature population, implants, bone grafting, partial dentures, or complete dentures can be considered. In type 2, these individuals have regular sized and supported teeth, so they have less invasive options. Their options include coronal coverages with fixed prosthodontics or aesthetics to help with discoloration.